All right, we're going to get started. Welcome back, everybody. Our next presenter is going to talk with us about how you can take a more active role in managing your lupus. Please help me welcome Jennifer Caing, immunology nurse educator from GSK. Thank you so much for being here today.
Thank you, Kathy. Good afternoon, everybody. I know it's late in the afternoon and everybody's probably a little bit sleepy. So if I could have a piece of your attention, that would be great. My name is Jennifer Caing. I'm an immunology nurse educator, and on behalf of GSK, I would like to thank Lupus LA for giving us this opportunity to be able to share with you some helpful tips, resources, and tools so you are able to manage your lupus and, play an active role in managing it. So first of all, I would like to ask, and anybody can answer this, why do you think is it important for patients to take an active role in managing lupus? Why do you think it's important? Why not just rely on just your physicians? Let them do it. Why do you have to play an active part? Yes. Perfect. So basically it gives back the control to you. You have better control of things. And basically nowadays, with healthcare, the focus is really patient-centered care. And when you say patient-centered care, patients really now have a say in whatever the healthcare plan is. It's gone are the days wherein patients play a passive role, wherein it's the physicians who call the shots and you're just like more of a yes man. So gone are those days. This is the new age now. And with healthcare changing, more and more it's going to be that way. So how do we take an active role in managing lupus as patients, as families, as friends of patients who have lupus? First of all, top on the list would be eating healthy and staying active, most definitely. Don't you agree? Yes? Okay. So it is important to really talk it out with your healthcare team, particularly about a heart-healthy diet. So by a heart-healthy diet, I mean like your fruits and vegetables. You have your whole grains. You have your lean poultry and fish. Those are examples of a heart-healthy diet. Mainly eliminating, if you can, in as much as you can, eliminating, high sodium, high sugar foods. And of course, when you maintain a healthy diet, it also affects your energy. It actually raises your energy levels, so you're able to do more. Second on the list is listening to your doctor's instructions. And I say listening because, again, you have to work collaboratively with your healthcare provider. It's not just them calling all the shots. So listen to what they have to say, but at the same time, work collaboratively with them in developing a management plan that is suitable for you, that is right for you. Because as you know, lupus is a fingerprint disease. Not all lupus patients are alike. Now, maybe what works well for one lupus patient may not work well for you. So, which is why you really have to have that one-on-one conversation with your physician. And if it so happens that the management plan that you come up with doesn't work for you, or you feel like you're having a problem sticking to it, then again, address that with your healthcare physician or with your healthcare team. Again, as a team, you can always look for a solution that works for you. So, the third thing that can help you control your lupus is being sun smart. We just had a discussion prior to this about, taking care of our skin and trying to limit our exposure to sunlight. And by doing that is, again, avoiding as much exposure. We all know that we live in sunny California where, it's always sun, sunlight is always there at 365 days of the year for the most part. So be sun smart and wear, you can use sunblocks. You can wear a hat, long sleeves, pants, and sunscreen, to have that protection that you need. It is important to involve your family and friends because basically, don't you agree they're the best source of support that you can get? Don't be afraid and don't be ashamed to ask for help. It doesn't mean that it makes you any less of a person just because you're asking for their assistance. Now, by assistance, that would mean it can be emotional support. It can be asking them to help you out in running with errands, or even as simple as if you have a doctor's appointment, that extra person being with you, it makes a lot of a difference. And again, don't feel intimidated or don't feel any less of you just because you are leaning on somebody else for help. Now, the most common challenge in managing lupus is what you call a communication gap. And this communication gap basically happens between patients, their caregivers, and that would include their physicians as well. Now, in 2011, there was a survey that was done by GfK Roper North America, and they conducted this survey conducted a survey of like 957 members of the lupus community. And this involved patients, their caregivers, and also rheumatologists. And as a result of this survey, a serious gap between what patients were really feeling and what patients were willing to share with others, and that includes their physicians, there was a serious gap that they noticed. In fact, there's 52% of these patients basically reported that they minimized their symptoms when they had that conversation with their physicians. And on the physician side, there's about 72% of them that were basically unaware that patients that they see tend to underreport the symptoms every time they see them. So that's a huge gap right there. So always remember that the first step in taking control of your lupus is really having that open, honest communication with your healthcare team. And as you know, communication is the best way to ensure that you get the support that you need. So I have up here on the slide a testimonial from an international renowned rheumatologist and researcher from Columbia University Medical Center. She's been practicing rheumatology for 15 years, basically specializing in complex lupus. And her name is Dr. Anka Askanase. And if I were to quote her, she said that, "I have seen these challenges reflected in my clinical practice. It is critical that patients and physicians understand the importance of clear communication because it has implications for disease management. For example, patients may not mention low-level disease symptoms as they may consider it a normal part of living with lupus. However, low-level disease activity can still cause organ damage and may represent a missed opportunity for identifying a flare and instituting early intervention." So basically what she's referring to is if patients tend to underreport symptoms and physicians are not aware of it, then they don't really have the best picture of what's really going on, and that would mean missed opportunities to get the right treatment for whatever they're going through. So again, monitoring of lupus, it should be a team effort. So that includes the patient, the family, friends, and the physicians that they see. Shared decisions and communications and open communication are imperative. So there has to be open and honest communication. And really, there might be instances wherein you will get into certain conversations that are not comfortable for you. I highly challenge you to go through it, because it's only then that you're able to uncover, the challenges, and you can work as a team to come up with the best solution. And always remember your healthcare team is there to support you. Now, may I ask one of you guys to please read the quotation up front, and this is coming from Rena. She is a patient who is living with lupus, and I want you to read it out loud for everyone to hear. And this basically explains why communication, how communication builds relationship. Anyone? Can anyone read it? Would you? Yeah, go ahead. Thank you so much. So that's how you know communication is really important in building relationships. All right, so I am going to give you a few moments. There are 4 questions up front. If you can, go through each question and do a little bit of some self-reflection. And I will most likely ask one of the 4 questions, because we don't have much time. Just so, we have an active discussion on it. If you can just read through it, I'll give you a moment. All right. So if I were to ask the audience, all of you, how would you describe, what does good communication with your healthcare team look like? Or how would it sound like? Yes. Perfect. Any other else who wants to share how good communication would sound like? Yes. Yes, perfect. Alrighty. So, yes. I agree. Anybody else who wants to share? Yes. I agree. Because most of the time they don't really have that luxury of time. So, I agree. Yes, one more. So prompting you, like asking you for more. Yeah. Good. Thank you so much for sharing. Moving along. These are some helpful tips when you have that communication with your healthcare professional. So again, discuss all symptoms. Now, it doesn't matter whether, sometimes we're unsure. I'm not quite sure if this is lupus related or not. It doesn't matter. You really have to put it out there. Share it to your healthcare professional. Also, it's worth sharing to your healthcare professional even symptoms that have disappeared. That way they know on whether or not, there's improvements, right? Don't you agree? So not just sharing the bad, but also the good stuff. And then I highly encourage you to bring a list. Always have a list with you of all the providers that you see, because most likely you see more than one physician. I would think so. So always have that list ready. And again, also bring a list of all the medications that you're taking in every medical appointment that you have. Because again, physicians don't really have that luxury of time. You're lucky if they're able to give you 15, 30 minutes, right? And there is this Ask Me 3 program, wherein these questions were designed by the National Patient Safety Foundation. And these are the following questions that most likely would trigger to open up, better communication between you and your physician. First, you can ask, what is my main problem? Second, what do I need to do? And third, why is it important for me to do this? So take note of these 3 questions. I highly encourage you to use these to open up your communication. And again, one of, the lady back there said, what was your name? I'm sorry. Yes, Denise. Yes, Denise mentioned earlier about education, right? So education is power. Knowledge is power. So it's always good to be informed and stay active in being educated in lupus. And this is why you're all here, because you want to know more about lupus. So you're already doing one of the steps in, managing your disease by being here. All right. So knowing more about lupus will, result to have better communications or being able to have a better conversation with your healthcare team. Again, it's also important for you to know what tests does your healthcare team do in order to monitor your lupus. So these are just examples of it, of some of the tests that they do. It could be routine blood tests. They can sometimes do urine tests to try to check if there's kidney involvement. And they can also test for antibodies. These are just examples, your anti-nuclear antibodies and your anti-double-stranded DNA, which usually these are the 2 common antibodies that they check for to know if there's ongoing inflammation. Another thing that's important in managing your lupus is keeping track and reporting accurately. So keep track of all your symptoms regularly. So you can report these to your physician, on a timely manner. And one way there's multiple ways of doing it. You can either keep a journal, so like a diary, so you can write it down. If you're old school, then you can do that. You can involve your family and friends. So you have, again, an extra support system, because again, if you go through that lupus fog and you forget easily, then at least you have other people to ask. For those of you who are techie, there are available apps online and even on your mobile devices that you can use to monitor symptoms or to track your symptoms. And again, have your medical records readily available to use as reference. Also share important factors to your healthcare team, like Let them know how your symptoms has your symptoms changed over time. How has your symptoms affect your daily life? And do your symptoms prevent you from doing things that you normally enjoy? And does lupus make you feel isolated, depressed, or frustrated? Those are worth sharing to them as well. Okay, another self-reflection. So I'm going to give you a few moments to look at the questions. All right. So let me ask you the very last question that's up there. It says, can you share to us if there was there ever a time that you were going through symptoms and you did not report it to your physician, and how did that play out for you? Have you ever experienced like having symptoms and you just told yourself, oh, I'm not going to tell my physician about it? Has it ever happened to you? Yes? No? Yes? Mm-hmm. But if, like you're saying that your pain is not as bad, do you still let him know though? No, not at all. And I'm curious to know why not. Okay. Or it's tolerable maybe? You feel like it's tolerable enough that it's not worth the doctor's time, you feel? Yeah. Okay. Fair enough. Yes. Okay. Yes, you should. I mean, even the littlest pain that you have, because at least they'll know, oh, okay, the last time I saw you, your pain was up here, and now so you're doing better then. So it's a measure of, are you getting worse or are you getting better? So worth sharing. Yeah, one more. Yes. Yes. Yeah, that's true. But still you tell him anyways, right? Yeah, that's good. Anybody else who wants to share before I moved on? Yes, one more. Mm-hmm. Yeah. Absolutely. And I applaud you for doing that. You're brave enough to do that. Not everybody does it because they get intimidated by, the physicians might get mad at me, or they may think I'm complaining too much. So, your healthcare team, they're experts of the disease, but you are the expert of how you feel. So, go ahead and share away. All right. Thank you for sharing that. Okay, resources. Let's move on to resources that's out there. Again, I mentioned to you, it's patient-centered care, right? So you are front and center in all this, you, the patient. And you are surrounded by support system. You are not alone in this journey. So who comprises that support system? Of course, your family, first and foremost, your friends, your healthcare team. You have patient advocacy groups. I'm hoping that you are a part of, there's a lot of patient advocacy groups out there. Lupus LA is one of them. And I wanted to share to you that GSK has come up with a website that is really made especially for patients, families, and friends to not just know more about lupus as a disease, but also it has tips, it has tools, and it teaches you skills to be able to face this challenging disease. So we have tools that's in the website, and these are the tools that's in the website. You have I'm going to move forward. You have your Lupus Checklist, wherein this is on paper. You can utilize this. This is downloadable. It can be found in the website. You're able to download this. And you can use this checklist to monitor and track your symptoms and risk factors. And, if you want to bring this, I highly recommend it for you to bring this during your medical appointment, so your doctors are aware what's going on with you, because you're keeping track of your symptoms by using the Lupus Checklist. Another tool is what we call the Lupus Impact Tracker, and this tool basically measures how how lupus is affecting your life on a daily basis. So, preferably you can use this tool. You complete it once in every 4 weeks, and then again share the results with your healthcare team. There are actually numbers, like you can rate it in terms of severity, and the lower the total score, that would mean the better you are in terms of your lupus, and of course the higher the score on the impact tracker, that would mean there's a lot to be done in terms of your disease activity. And then we have this another way of tracking your symptoms, and this is by an app that GSK created. It's called My Lupus Log. And this is actually available for you to download not only on the Android phone, but it is now available on your Apple phone. And, if you're the type who doesn't really want to use paper stuff and, you're not fond of journaling, you can actually, download this app for free. And it's easy because you bring your phone wherever you go, right? So you don't even have to remember to bring anything with you because you have your phone with you all the time. So when it's time for you to see your doctor, you can just take this with you, open up the app, and for as long as you're recording on a regular basis, you can show this to your physician. And again, the old-fashioned way is again doing a journal or a diary. So this would actually enable you to just jot down, your thoughts, your feelings about anything. And again, if you want to share what's in your journal to your healthcare team, please do so. And then we have the appointment prep guide. Now, this appointment prep guide would really be helpful for you guys to give you more structure when you prepare or as you prepare for your doctor's appointment. That way, and again, because I mentioned to you earlier, physicians have very limited time to spend with us, patients. So, make good use of their time and your time. It's better for you to utilize this prep guide. That way you know what to bring, who to bring with you during the appointment, and what would start or spark a good conversation. So again, what's worth sharing to the physician, because there's only limited time. We also have this Lupus Dictionary wherein, it has medical terminologies, and, you'd be able to familiarize yourself with the most common terminologies that's being utilized when we discuss lupus. That way, it's easier for you to have that conversation with your healthcare team. So last reflection, if you were to go over the 4 questions for me for a few moments, and then I will ask just one question and ask one of you to echo back and answer. Okay. So among the tools that I shared with you earlier, what was it? The Lupus Checklist, the Lupus Impact Tracker, you have the My Lupus Log, you have the journal, you have the appointment prep guide. So among those tools that I mentioned, what do you feel, or what do you think would be useful? Do you think it would be useful for you to utilize from here on moving forward? The Lupus app? Yes. What else? Any other tools that I mentioned that I didn't know that there's a tool for this, and I'm going to start using this moving forward, aside from the app? Yes. Lupus Dictionary? Yeah. Perfect. Yes. The journal? Yep. Actually, it's worth your time too, because that way you can jot down, your symptoms there too. And you can actually monitor your progression, like, am I getting worse or am I getting better? Perfect. Any other? Yes. 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 The My Lupus Log has that. It's like a calendar. Probably when I get done, I'll come to you and I'll show you. I have it on my phone, so you have an idea how it looks like. Yeah. I have it in my phone, so I can show it to you later on. Any other tool that's worth your time? What about the website? Yes. I have to ask for that, but I don't think there is. But I'll ask just to be sure. I don't think so. I'm not quite sure. I don't think it is. Yeah, it's just an app for you. But I can always ask for clarification just to be sure. Yes. Well, are you seeing a rheumatologist for your lupus, or is it just a primary physician? And my question is, are they all on the same page? Are they talking to each other? Is there a communication between all of them? like a coordination of care, because that's really important. Yes, I understand, but I highly recommend for whoever is taking care of you, how many doctors you have, that's a part of your healthcare team, I highly recommend for them to coordinate stuff. That way, if you use this app, you can use it, you can show it to all of them. Because they're all on the same page. But if there's a disconnect, it would be hard. Really. I highly recommend that there is a coordination of care. So everybody knows what the others are doing to take care of you. So, all right, let's move along. So again, I highly recommend for you to seek additional support, patient support. There are local advocacy groups out there. There's so many. Reach out to lupus organizations and educational programs. These are just examples of it. Lupus LA is one of them. So I highly recommend for you to check these out. For more education stuff and for more support, patient support. Again, remember, you are not alone. Don't be embarrassed or ashamed to ask for help. Utilize your healthcare team, utilize friends and family, and get them to be part of your support team or support system. And in closing, at the end of the day, you are the most important component in managing your disease. You play an important role. Always bear in mind to keep an open and honest communication with your healthcare team and with your other members of your support system. Take advantage of the tools and resources that's out there, including the resources that I shared with you that's found in usinlupus.com. And of course, again, stay active in keeping yourself educated because knowledge is power. So can any one of you read this patient response to close my spiel? Yes, anyone? Yes, go ahead. Don't you agree? Life is just too short and precious to take it for granted. So I challenge you, be empowered and be your own advocate. Thank you so much.
Do we have any questions? You can write it down near the index cards.
I believe it's in each of your packets you have a brochure that says Us in Lupus. So at the very back of that brochure there is a business reply card, and if you fill that one out and send it back to GSK, once we get it, we will be mailing to you symptoms reference kit containing all those tools that I told you about. So the journal, the lupus impact tracker, the lupus checklist, it's all part of that kit for as long as you mail that back to us. So I highly encourage you to utilize it. Okay, so what is GSK? GSK stands for GlaxoSmithKline, and it is a pharmaceutical company. And we are actually, I'm sorry? Okay, so GSK it stands for GlaxoSmithKline. It's a pharmaceutical company, and we are highly involved in the research and development of, medications that would help out, diseases such as lupus, but we also invest on patient education like this. So that's basically GSK, and we go by, our like company motto, which is do more. We want to do more for patients so you can feel better and live longer. That's our mantra at GSK. How can we find out the answer as to whether or not your app tracks people after this? I will find out for you. And I will relay it to, is it okay to give you the response, Kathy? And you can just circle back with Kathy. Because I totally understand privacy. I know privacy is a concern. Yes. Thank you so much.
Thank you, Jennifer. We appreciate it. Our next presentation, we're going to learn more about lab tests and lupus. Dr. Christine Lee is a rheumatologist. She completed her rheumatology fellowship at the Stanford School of Medicine, and she joined Dr. Wallace in private practice in 2017. We're very grateful to have her with us today, and she's going to be presenting on lab tests and lupus. So please help me in welcoming Dr. Lee.
Hi guys, so wrapping up the session today, I'm Christine, I work with Dr. Wallace, and today we'll be talking about lab tests and lupus. I'll try to keep it more informative and engaging and less dry, but let me know how you feel about it. So topics of discussion, we'll be talking about the difficulty of diagnosing lupus, antibodies, the significance or lack thereof, testing, prognosis, and other useful diagnostic tools. So patients report waiting nearly 6 years from onset of symptoms before receiving an accurate diagnosis of lupus. There seems to be a disconnect between patients and providers in this aspect. As we said, they report nearly 6 years to obtain a correct diagnosis of lupus and usually have seen an average of 4 different physicians. Now, rheumatologists report being able to diagnose a patient with lupus in 2 to 3 visits. So, are we getting it right? People have looked into the diagnostic accuracy for lupus and other systemic connective tissue diseases in the community, and this is not just rheumatologists alone, but primary care physicians too. 263 patients referred to a lupus center of excellence had a final diagnosis that differed considerably from the referring diagnosis. 76 ANA positive patients who had no autoimmune disease and 39 were incorrectly treated with steroids at dosages as high as 60 milligrams. So you can see where this might become a problem. In the non-rheumatologist population, 47% had a non-lupus misdiagnosis at time of referral to a rheumatologist, while at the same time 27% of other rheumatologists referred to this center also were given a different diagnosis. So what makes diagnosing lupus so challenging? Part of the problem that patients have reported is they tend to minimize their symptoms, and some of you might feel this way too when talking to physicians. At the same time, 72% of physicians were unaware that patients tend to underreport their symptoms. Symptoms and antibodies can evolve over time, and that can become an issue because you expect when you go see a doctor, you'll find out an answer right away, but sometimes that's not possible. No single biomarker has adequate performance for this diagnosis. The anti-dsDNA is only 33% positive for many patients in many studies. There's also unreliable or inconsistent lab results. There's different ways to test for the ANA. There's an ELISA and multiplex technology that are actually considered second line to the immunofluorescence IFA way of testing that we'll talk about in a little bit. So timely and accurate diagnosis is important, as we know, as it affects both costs and clinical outcomes. Now, what makes lupus so hard to diagnose? Looking at the criteria for diagnosing lupus, you see there's skin criteria, there's whole body organ criteria, and there's laboratory criteria. You can have a butterfly rash, a discoid rash, sun sensitivity, mouth ulcers, arthritis, serositis, meaning inflammation of the lungs or the heart, kidney diseases, or neurologic disorders. Looking at labs, you can have blood abnormalities, immunologic disorders, antiphospholipid antibodies, lupus anticoagulant, DNA antibodies, Smith antibodies, or even a false positive syphilis test or the RPR. You need to have 4 of these 11 criteria needed for a diagnosis, with at least 1 being from the laboratory side. So as we looked from the previous slide, no single test can determine whether a person has lupus, but several lab tests can help make the diagnosis. This includes the ANA, the DNA, Smith, the RNP, and the Sjogren's antibodies, which are the anti-Rho or SSA, and anti-Law or SSB. There's also the anti-Cardiolifepin antibody, the antiphospholipid antibody, and sometimes tissue diagnosis is really the best way to find out, because tissue is the issue, and you can actually see an immune complex formation in either the skin or the kidneys. So what is the best way that the American College of Rheumatology has decided to test for the ANA? This is actually through immunofluorescence, and what we use are human epithelial cells, also known as HEP2 cells, and they serve as the base for testing patient serum. So there's this base that you add your blood to, and if antibodies are present in the blood, you'll see them light up with this immunofluorescent material, and you can detect this by microscope, and depending on how often you add the blood and you dilute it out, that becomes your ANA titer. And we'll talk about that a little bit further. So the problem becomes, for a variety of reasons these days, ANA testing is being referred to high throughput service labs. So instead of taking the time to do the immunofluorescence, people want to run a lot of blood from different patients at the same time to save money, and thus they'll use different ways of testing, such as the ELISA or the multiplex. This complicates things and gives a more non-specific picture. So false negatives result because there's a limited number of antigens that are used in these other types of testing, and the immunofluorescence way has more antigens, so it makes it more likely you can pick up on the most accurate antibodies that a patient might have. So the failure to diagnose using these other tests is as high as 35%. This also becomes a problem when patients are referred to us, because we often have to repeat the testing again, or you go to different physicians and have repeat testing done. But where were the tests done, that does make a difference, and then this drives up costs due to the repetition of testing. So ANA patterns, as you might have seen from your lab results, oftentimes after you see the titer, you see a pattern resulted, and there's the diffuse or homogeneous pattern. Typically for lupus, this is most common. It's also seen in rheumatoid arthritis patients. There's also the peripheral or rim pattern that you see on your right, and that is also highly associated with lupus. Other types of patterns are the speckled pattern, and that is associated with Sjogren's and scleroderma, and then the nucleolar pattern, which is scleroderma and Raynaud's. So the titer, as I mentioned earlier, is how many times the patient's blood can be diluted and still find antibodies present. So a higher titer means a higher concentration of antibodies and therefore more accurate diagnostically. So whereas we may not think of a 1 to 40 ANA as being particularly alarming or even significant, say a 1 to 1280 definitely would raise more of an eyebrow and would let us delve more into exactly where the antibodies are coming from or what is driving this process. So the sensitivity of an ANA test, which means the likelihood that when you have a positive, it's actually accurate, is quite high. So over 95% of lupus patients are positive. Now this means that if your ANA is negative, the chances of having lupus is actually quite low. Now the ANA, though, lacks specificity for lupus. So while someone who has a positive ANA is more likely to have lupus, it does not mean that you do if you do have a positive. Now there can be lots of false positive tests, like I mentioned, if there are different ways of testing done, as well as simply 5 to 15% of a healthy population can have a positive ANA, and it doesn't necessarily mean anything. And as we get older, especially for women, about 70% of 70-year-old women across the board have a positive ANA, and it doesn't mean they have lupus or another autoimmune disease. It can also be present if you have other autoimmune diseases, such as rheumatoid arthritis or commonly Hashimoto's hypothyroidism. It can also be positive if you've had a chronic viral infection in your life, such as hepatitis C, mono, HIV, or if you've had a history of TB. Certain medications and antibiotics can also cause a positive ANA, so commonly doxycycline, minocycline, and blood pressure medicines such as hydralazine can cause a drug-induced lupus. Now, this is why we have other criteria to help us out, because you can see this can become very complicated. Looking at the prevalence of ANA in the general U.S. population, so this was a national health study looking at 4,700 individuals. Almost 14% of individuals older than 12 years of age were positive. Now, they had a higher prevalence in African American females, older individuals. 32 million people in the U.S. have elevated ANAs, but only less than 1 million have lupus. 98% of people with lupus, though, will have a positive ANA. And this, we don't have to go over the whole thing, but mostly if you look at the top with the lupus and the sensitivity, you see that it is very sensitive, the ANA, particularly for lupus, and less than 50% for, say, rheumatoid arthritis. Looking at more specific antibodies, so the double-stranded DNA is positive in about 60% of people with lupus. It's highly specific and very rarely in low titers, as is seen in other inflammatory conditions. So this antibody we will often check more often than the other ones because it can correlate with disease activity, and it's most often in active lupus nephritis. Therefore, we use it as a way of monitoring disease activity in these patients. The Smith antibody is also specific, but less frequent than the DNA antibody. So it's positive in about 10 to 30% of these patients. And both of these are part of the criteria for lupus, but you don't have to have them. Now, also in the criteria for lupus are antiphospholipid antibodies, which are clotting antibodies. They bind to blood vessel walls and clotting proteins in the blood. They can cause blood clots both in arteries, such as a stroke, or veins, something we call phlebitis, and also the placenta of pregnant women, and that leads to a higher rate of miscarriage. So ignore that little choose a fill type. But in 1/3, so antiphospholipid antibodies are found in 1/3 of patients with lupus, and 1/3 of those patients will actually have antiphospholipid syndrome. To have the syndrome, you need to have all 3 antibodies. So you need to have a lupus anticoagulant, the anti-cardiolifin, and then something called beta-2 glycoprotein. You see the reagent on the top because that is what's tested in something called the rapid plasma reagent, which is the test for syphilis. So actually in the past, before we had more specific test for syphilis. This was the screening test, and many young women who had not been sexually active had a positive RPR, and it was very hard to explain why. But now we know that actually it's because they have a positive lupus anticoagulant, and it can cause cross-reactivity in the blood. So that caused some miscommunication in the past, but we do explain to people now. We're not as surprised anymore when we see a positive RPR. So the cardiolipin is pretty significant in that it can cause various types of clotting disorders, not just in the autoimmune world per se, but also in dermatology, pulmonary diseases, and cardiology. All of these are clotting type diseases though. So for example, cardiology, Liebman-Sachs endocarditis is a non-infectious endocarditis of the heart where you have little deposits of tissue on the heart valves, and everyone gets concerned that it's actually infection, but it's not. It's just because you had a proclotting disorder. And more commonly, blood clots and blood clots in the lungs, blood clots in the legs. So we've talked a lot about the antibodies with lupus, so this kind of just more so points out all the different types of testing that can be done and whether they are lupus specific or not really. We'll just gloss over this. Now, looking at this, what I want to hone in again is, yes, the ANA is very sensitive, but not as specific. Looking at the more specific antibodies for lupus, like the DNA and the Smith, as well as complement levels, you'll see that they're not so much sensitive, but they are very specific. So if you do have these particular markers, they do point towards having a lupus picture. Now, it's important to also look at the blood count in lupus patients because you can have all sorts of abnormalities in the different types of blood cell counts. So you can have anemia due to something called hemolysis, which is autoimmune destruction of your red blood cells, and this causes an anemia. You can also have an immune complex-related decrease in your platelets, as well as most commonly is you'll see your white count is a little bit low, and that's generally okay, but we do worry when people's white counts drop below 1 or 1.5 because that makes you at a much higher risk for infection. Now, non-lupus causes must always be considered, so there are lots of medications and even the biological agents or disease-modifying DMARD drugs that you're on, they can also cause a little bit of drop in blood count, or infection you have to rule out, or actual blood loss. So summary of useful tests in lupus. This is sort of a guide for you as a patient and what you would expect to have done if you're getting worked up or what you should have done at routine testing. So we always get a blood count. We check the urine because it's very important to screen for kidney disease. We check the metabolic panel. We check your SED rate, which is a marker of inflammation, as well as the C-reactive protein. Complement levels, as I mentioned, because those are quite specific for lupus. Sometimes x-rays and imaging are helpful depending on what your issue is, whether it's arthritis or heart disease, an EKG, and then the ANA and dsDNA. Now getting into a little bit more specific testing, stuff you may not do at every routine visit, but is important to think about depending on what the situation is, are clotting tests, so the prothrombin time, your INR, and then your PTT. Sometimes are tested to see if you're at higher risk for bleeding. Also doing an echocardiogram of the heart is important to screen for any sort of signs of heart failure. Checking a rheumatoid factor and a CCP. These are both antibodies for rheumatoid arthritis. And we often do see an overlap between rheumatoid arthritis and lupus, or something we call rupus. So it is important to look at this as well. And then bone density scans are important to consider, or even earlier than in the general population, because of when the disease strikes, which is normally when you're 20 or 30 and you've been on steroids for quite some period of time, then that can make you more susceptible to osteoporosis. Now, going into more advanced testing is the reflex panel testing that we look at to see all the other different types of antibodies you might have. So like I mentioned, this is where all the more specific testing comes into play. And then level 4 is when you have end organ disease or you're concerned about end organ disease. And this is when one might do CTs or MRIs, especially of the brain for vasculitis or ruling out neuropsychiatric lupus, something like that. EEGs, which are electric ways to check for if there's seizure activity, as well as EMGs, which is a muscle test where you stimulate the nerves and look for any sorts of inflammation there. Bone scans can often identify any sort of inflammation in the body, and it's helpful when we're looking at whether someone's pain is related to true arthritis, true inflammatory pain, or fibromyalgia. Because if you have fibromyalgia, your bone scan won't light up, so it can be helpful in that respect. And then there's more specific testing, too, to look at if you suspect someone has drug-induced lupus, the antihistone antibody can be helpful for that, as well as if you're worried about hemolytic anemia, then the Coombs testing will be positive if you're consuming your own red cells. So this is looking at the incidence of clinical and lab findings in lupus. So most commonly, yes, we know you have to have a positive ANA or it's going to be positive in 97% of people. Arthritis is one of the most common symptoms, as well as skin changes, muscle aches. Then it goes into having low complements or a high DNA, fevers. As you look through these, you'll probably identify with several of these symptoms, as well as lab changes. So what can we conclude about ANA testing? So using ANAs as a population screening tool is not really recommended. It gives us way more false than true positives, especially when you consider all the different types of testing out there and the different ways to test. And using an ANA as case ascertainment really depends on your pretest probability. So like I mentioned earlier, what symptoms do you have? Is it worth testing for an ANA? Is it something that should be tested? And just as we would for rheumatoid arthritis using a rheumatoid factor or HLA-B27 testing for ankylosing spondylitis, you do have to think, like, why am I testing this instead of just blanket testing for it? So with signs and symptoms, having a positive ANA with a titer about 1 to 160 has good sensitivity and specificity. But like I mentioned before, the predictive values do change as the population gets older, being that people ages 70 and older will just naturally have an anti-ANA. And so really this requires getting to a rheumatologist and being assessed more thoroughly, and that's the problem. As I mentioned at the beginning of the talk, is the disconnect between patients having symptoms, reporting symptoms, and seeing different doctors before they get to one who makes the right diagnosis. The problem is, when does lupus even begin? So there's emerging data that shows that cytokine pathways are activated even before antibodies become positive. So how can we take this into consideration? So looking more, there's into population-based studies. So the Department of Defense had a serum repository. So the OMRF study, which is the Oklahoma Medical Rheumatic Foundation, they looked at 130 subjects who had received a diagnosis of lupus, and they had blood from before the diagnosis to compare this to. So they found that these patients had ANAs present in 78%, 55% had the dsDNA, and 47% had Sjogren's antibodies. Controls were 3.8% positive, having these antibodies. They found these antibodies present years before diagnosis and also seemed to appear in a predictable sequence with progressive accumulation, like a higher titer before diagnosis. And after going back and looking at chart reviews, it looked like many of these antibodies had actually been present even years before anyone had any symptoms. Interestingly, the earliest appearing antibody tended to be the anti-Rho or SSA. So the findings suggested 3 phases. First phase, where you have no symptoms or antibodies. a second phase where you have positive but benign antibodies where they're there, but they're not really causing you any trouble and you don't even know they're there. Then there's a third phase where the bad antibodies, such as the Smith and the DNA, which are the more specific lupus antibodies, are present along with symptoms, and that's when you get the diagnosis. So this was the New England Journal of Medicine article that published this data. And we'll show a better graph here because there's a lot of numbers here. But what they looked at were these different antibodies and then what percentage had a positive test before the diagnosis, which you'll see is the highest for the ANA, 78%. And then what I found interesting was the interval between positive test and diagnosis was about 3 years for the more specific antibodies, and then about 2 to 3 years between having a positive test and an onset of symptoms. So looking at this graph, I think is just easier to relate to because it shows, okay, the diagnosis was at year 0, we'll say. Well, 6 years prior, they found some development of antibodies in these patients' blood. About 6 months prior to diagnosis is when most people experienced a clinical onset. So something happened that wasn't right, was different from before. And then you make the diagnosis. And so this happens with rheumatoid arthritis and other antibody-mediated diseases too, where people are fine for a long time and then something happens. And what we think is, so there's normal immunity that we all have to fight infections and for general living. And then there's benign autoimmunity where you have antibodies, but nothing bad has happened at all yet, or maybe will never. But then you have some sort of genetic influence as well as environmental triggers that we haven't really identified, except for with lupus, certain things like alfalfa sprouts maybe, or like smoking, that might be an influence, but we don't know for sure what exactly is the right trigger for any particular patient. This creates pathogenic autoimmunity and then clinical illness. So that's kind of the general picture for autoimmune disease as we know it at this time. So in conclusion, as we can see, lupus is a very heterogeneous disease, different for everybody, every individual. It's not defined by a concrete set of lab markers. So we use them to help us track disease, but it's not diagnostic at all or confirmatory in any way. And there are fluctuations in your blood count and your inflammation markers with every routine visit that you go to. So it's not the minute differences in lab values that make the difference. It's the whole picture. So I would say don't harp on every single lab value because it may not be that significant. Like an inflammation marker of SED rate from 22 to 24 is not that significant. So it's taking everything into consideration, the person as a whole, looking at antibody testing, symptoms, and then exam findings. And then while I just mentioned that antibodies can predate the onset of disease, it is generally not recommended to conduct ANA screenings in the general population because we don't ever know if these antibodies will lead to disease. And so even if you do have a positive ANA, there's nothing that we would do, and this is what I explain to patients all the time, there's nothing we would do at this time. I would never put you on immunosuppressives and shut down your immune system for no reason as I see it at this point, but it's something to monitor over time. And definitely, especially in the first 3 years that I see someone with a positive ANA, I always want to monitor them every 6 months or once a year just to make sure they're not developing into an autoimmune disease. And so I think that's the main part to get out of this. And that's pretty much it. So if you have any questions, let me know. Okay. Dr. Wallace offered to email audience members a copy of his PowerPoint presentation for future reference. Will you do the same? Yep. I'll make sure I get that info from Catherine, and we'll get that out to you guys. Okay, so is vertigo common in lupus? If so, how is it treated, and what can cause vertigo in lupus? So vertigo as a symptom alone is usually not due to underlying lupus. It can be related to certain drugs you're on, or if you're on any blood pressure medicine at all, then certainly that can cause vertigo. Usually we refer people to a neurologist to see what the issue is. Most commonly vertigo is something called benign positional vertigo, or BPPV, and actually that can be corrected when the right doctor does a sort of test where they twist your head around really fast, and it's called an Epley maneuver, and that will oftentimes solve the problem. But as a symptom alone, it's not really associated with lupus. Okay. So if patients with organ damage and on medications for more than 10 years, could the medications have been the cause of the damage over time? So depending on what the issue is, yes, medications can cause damage. So what I can think of in particular is something like Selcept or Imuran, azathioprine, has been linked to a higher rate of blood disorders. So not necessarily full-blown lymphoma or leukemia, but certainly something called MGUS, which is monoclonal gammopathy of undetermined significance. There is a higher risk of a hematologic malignancy being on these drugs long-term, which is why we always hit you hard in the beginning, and then we try to taper patients off of medicine over the years, or at least to the lowest effective dose. Or you can always switch someone who's been on Imuran for 10 years to Selcept instead, so you're not always taking the same drug, and so that might help. You listed certain medicines here, and Plaquenil, generally, the only thing is, as you all know, you should have your eyes checked once a year because it can deposit in your retina and cause a retinopathy. This is based on cumulative dosing, though, so it's not going to happen right away. It's if you're on a high dose for too many years, there's a certain amount of toxicity or dosing that your eyes can tolerate. And so once you reach that point, that's usually when the eye doctors and your regular rheumatologist will say, oh, maybe we cut you down or we can watch you off of that. Other drugs listed here, prednisone. Well, we know prednisone can cause lots of side effects, especially, I would say, organ damage-wise. I mean, it can cause diabetes, and that's a major issue, as well as osteoporosis, another major issue. So those are the main side effects. Metoprolol is a blood pressure medicine, not really related, and then levothyroxine is a hypothyroidism medicine, not really related as well. If a lupus patient diagnosed for more than 10 years with organ effects on multiple medications be the cause of organ damage? So this was the same question, so we're okay on that one. Lupus patients that have lupus nephritis and need to be on IV infusion Cytoxan, what are the likelihood of success of needing more treatments or leading to kidney failure or transplant? So looking at using Cytoxan for lupus nephritis alone, there's basically been a study showing that Caucasians respond better to Cytoxan than minority patients do. So Asian Americans or African Americans, Hispanics, usually we actually might use Selcept first because it seems to work better in that population. But either one of those, the main key is that you want to get the diagnosis right away and start treatment. And once you're on the Cytoxan, we'll use this as an example because this is the one mentioned here. Usually you don't have to be back on the Cytoxan over time. We use it to basically give a huge slug of medication, calm down the kidneys, and then we switch to a different steroid-sparing agent such as Selcept or Imuran. So you wouldn't always need that. Now, some people do flare and they'll need to be redosed with Cytoxan, but it's not like a regular medicine you have to be on. So the anti-dsDNA, how much does this antibody influence or impact diagnosis? Is it related to other disorders or diseases? So it is pretty specific for lupus, and if someone has an ANA and a dsDNA, it always raises my interest to look further into whether or not a patient really has lupus, and I would look into seeing if they have inflammation markers or low complements. Typically in patients whose dsDNA tracks with their disease, which it doesn't always work for everyone, but for the people whose DNAs are high when their disease levels are high, their complements tend to be low. So I use both of them as adjunct thinking to see if that's meaningful. Typically we don't see it in any other disorders. So it is pretty specific. Now, sometimes if you have a cancer or something like that on a rare case, then you might have a dsDNA. But in general, no, it's pretty specific for lupus. Okay. So what is a good prophylactic prevention action to take prior to a likely pre-flare-up unavoidable event such as surgery? So what I have patients do if they're going into surgery or if they're about to undergo a big stressor or big divorce or traveling across the country, something like that, I'll have them bring a Medrol dose pack with them, and that's just a little burst of steroid that if you flare or if you feel like you're going to flare, you can take it, and it won't have any long-lasting side effects because it's only for 4 or 5 days. So that's what we do, and same with surgery. People will get like IV steroids before orthopedic surgery or cardiac surgery, anything like that, and that prevents a flare later on. Okay. So if someone, female, has Raynaud's syndrome and ulcerative colitis, a negative ANA in the past, but a mother with lupus, should the ANA be repeated? So I would say it depends on if there's any other symptoms going on and when the ANA was done. Say if it was done like 20 years ago and now you're experiencing something new, then it might be worthwhile to look at it again because you do have a family history, and ulcerative colitis is also an autoimmune disease. Okay. Can the bone scan detect avascular necrosis? The best thing actually is just an X-ray. Simply will show if there's any necrosis, but on a bone scan, it would still light up, but it wouldn't necessarily show that it was necrotic. Just any sort of inflammation or irritation or arthritis will light up on a bone scan. Okay. So just because we have antibodies, it's not a bad thing. What makes it bad? So what makes it bad is when these antibodies become pathogenic, harmful in some way. And that's kind of what I was saying, when there's something in the environment or you were genetically predisposed already, triggers your body to overreact and then create this system where your immune system attacks itself as well as fighting off infections. But that's when they become bad. That's the turning point from benign autoimmunity into pathogenic autoimmunity. Okay. Can ANA fluctuate between positive and negative? So the problem is we often do see that people will have a positive, and that's kind of what I was saying before is where did you get the testing done? Unless you use the same exact testing place, center, and technique every single time, you're going to have variations. I will say for patients who have had long-standing lupus and been treated with heavy agents such as rituximab or Cytoxan, big infusions, oftentimes your ANA will turn negative, but that's because we've knocked out all your B cells and you've repopulated and whatnot. So yes, over time, your ANA can become negative, especially if you've had a lot of heavy immunosuppressants. Okay. So can medications be the leading root cause to organ damage? Oh, we did this one already, so we talked about that. And then this one's interesting. Why can my blood work look perfect, but I feel horrible? And we do see a lot of people, or I have a lot of patients where this might be the case. So you really have to this is when the physical exam comes into play, and you really want to see if there's something physically there that you can see. Now, with inflammatory arthritis, you should see, say, like high inflammation markers. But this is when I delve into what's going on, what are your symptoms, how can we help you? Because oftentimes a big issue is, say, brain fog or fatigue, and you're not going to pick that up on labs. Your labs will look fine, but you have you're tired all the time and you have all these other more nonspecific symptoms. And this is when I encourage people we figure out a way to sleep better. We take deep breaths, meditation, things like that. Actually taking very deep breaths, like scheduled deep breaths, does help a lot with brain fog. And so I look at basically non-medical ways to treat symptoms and see what's going on. So every patient's different, but commonly I hear that brain fog and fatigue are big things. So I try to figure out what's the root issue and we go from there. Okay. I've been taking hydroxychloroquine since I was diagnosed in 2008. I would like to get laser surgery to correct my myopia. Is it okay to get laser surgery considering I'm taking Plaquenil? Yeah, so that would be something you would tell your eye surgeon about, but it really shouldn't affect the whether you take Plaquenil or not, because Plaquenil is only affects the retina, which is your primary source of vision, but the cornea and the way your eyeball is shaped, which is part of the problem with having nearsightedness or farsightedness, that doesn't get affected with Plaquenil, so you would be able to have LASIK without any issue. You just always should let your eye doctor know, but there wouldn't be a problem. All right, thanks. Yeah. Uh-huh. Uh-huh. Yeah, most drugs can actually cause a decrease in blood counts, but specifically our types of the DMARDs and the biologics, they can mess with your white count. And so if it drops to a certain extent too, what we most commonly do is we just tell you to hold the medication, and this applies to your red cells, your platelets, your white cells. See if they repopulate. If they don't, then oftentimes I'll send people to a hematologist, a blood doctor, depending on how low it is. If it's pretty low, then a bone marrow biopsy might be considered, and they would go from there. But generally, I would say, it probably is due to the Benlysta. I would just hold it and maybe recheck in a month and see how it is. Yeah.
Thank you, Dr. Lee. We really appreciate it. That was great. Thank you all so much for coming today. That is the end of our conference. Before you go, please do fill out the survey in your folder. It's the green sheet. We would love to hear your feedback. And when you are leaving, just as a reminder, when you take your elevator, you actually go down one floor to exit to get your car. So take it down one. And thanks so much for coming.